Yeah, thank you so much. My name is Dr. Derrick Abila. I am a medical doctor from Uganda. The work that I'll be presenting today is partly what I did with my affiliation with Makerere University, which is located in Kampala, Uganda. So I'll be sharing about a study. This was more of a secondary review of data from the population-based HIV impact assessments. So a brief background, there is currently a high burden of syphilis around the world, and in 2019, the reports from the Global Burden of Disease Studies showed that there were about 14 million new syphilis infections that were diagnosed, and almost a third of these were from Sub-Saharan African countries. The maps on the right just basically highlight the proportion and distribution of syphilis from this study. Why syphilis? Syphilis is an ulcerative STI, and this breaks the barrier and predisposes women to, and also men, to HIV infection because of the breakage in the barrier. And also, when I reviewed the literature, there is really a limited population level kind of data that shows the estimated burden of syphilis infection among those who are living with HIV, both men and women, but it was limited, especially in terms of the scope of studies. Most of the studies were limited to particularly hospital settings. So we really needed to understand how the current burden is, especially in a population level. And also, currently, there are limited or few kind of screening programs that are available for screening for screening syphilis in HIV clinics, especially in majority of the Sub-Saharan African countries. In this study, we aimed to determine the seroprevalence of co-infection of HIV and active syphilis among women who are living in 6 Sub-Saharan African countries. I'll highlight why we chose 6 countries out of the 54. In the methodology, we looked at already existing data. This was analysis of data from the population-based HIV impact assessments. These are rigorous studies that are done in collaboration with the University of Columbia, PEPFAR, through the Centers of Disease Control in the US. And basically, this is a partnership between these institutions and ministries of health within the different countries. And the major purpose of this is to find out the true actual burden of HIV in these countries. The first phase of these studies took place in 2014, and currently we're in the 3rd phase. But the current data that is available publicly is for the first phase that was conducted from 2015 to 2019. So the countries that I selected were 6. These are Ethiopia, Kenya, Tanzania, Uganda, Zimbabwe. And these are because they're the only countries that tested women for HIV at population level and also tested them for syphilis out of the 16 countries. The first phase of the surveys were done between 2015 and 2019. The population that I included were women who were diagnosed with HIV during these surveys, 18 years old at that time or older, and then were tested for syphilis. The various methods that were used for testing syphilis were uniform across the 6 countries. They used the dual path platform for syphilis screen and confirm assay. And then also, this was based on detection of antibodies against both the non-treponema and the treponema antigens. These are the different forms of syphilis. HIV viral load testing was also done uniformly across the countries. And this was based on plasma samples. There was a test that was assessing the recency of HIV infection, which is basically based on antibody avidity. I'll explain later. And all this data was analyzed in Stata, and most of the regression analysis was done using a log binomial regression model. So we took into account the weights, for the sampling weights that were provided in these data sets, and also reported adjusted prevalence ratios. In the findings, from all these countries, we included 8,000 women living with HIV. These were also tested for syphilis. The table on the left shows the distribution of the population across the different countries. majority of these women came from Zimbabwe, Zambia, and Uganda, and the majority were from Tanzania, a few from Kenya and Ethiopia. But a brief overview of the population, the mean age was 36 years with a standard deviation of 11.6. It was quite above the youthful age if you look at the median. About 50, slightly above half of the population was residing in urban areas. 48% were either divorced, separated, or widowed. 52% had primary education as their highest level of education, and about two-thirds had at least one sexual partner in the last 12 months prior to being surveyed. Also, slightly less than half, that is 47.8%, used the condom in the last sexual intercourse within the last 12 months. One thing that I also wanted to find out is what proportion of this population was pregnant, and about 4.9 were pregnant at the time of the survey. In terms of symptoms, of syphilis, of STI, not syphilis, but STIs that were examined among the population, about 17, among those who had active syphilis, about 17% of them had STD symptoms at the time of the survey. And then of those, only 32% actually sought care at a healthcare facility for the symptoms of STD that they had. And then also among those who had active syphilis, about 94% of those who sought care at the health facility actually had an STD diagnosis. And of those who were diagnosed with STD, only 36% had received treatment for their STD that was diagnosed. So in terms of the clinical picture of the women who had active syphilis, in terms of HIV, in terms of knowing whether they're living with HIV, among those who had active syphilis, only 30% were, 30% were aware, 30% were unaware that they're living with HIV. And then in terms of recency of HIV infection, among those who had active syphilis, 97.9% had long-term infection. And majority of them were on ART, that was 61.9. And in terms of viral load suppression, those who had active syphilis, 46.5% of them were not having viral load suppression. And CD4 counts were low, as we can see in this table. So when you look at the prevalence of co-infection of active syphilis and HIV, across all countries, the prevalence was 4.8%. But this, of course, varied across the different countries, with the lowest being in Kenya, where the prevalence of co-infection was 0.6%, and it was highest in Zambia, where it was 8.5%. So in terms of women who are living with HIV and pregnant, the prevalence was 5.6 across the countries. And why pregnancy? Because, in the case of pregnant women, one of the forms of transmission of syphilis is through the transplacental kind of transfer of infection, just like sometimes we have in other scenarios, like for example HIV. So in case of transfer of, or in case of the transplacental transmission of syphilis to the fetus, sometimes they may develop a congenital infection, and usually it's quite fatal. So that's it may be a very low percentage, but it's something that needs to really be addressed. So in terms of the factors that are associated with active syphilis and HIV co-infection, the significant factors that we found from the regression models was HIV viral load non-suppression, whereby women who were living with HIV and were not virally suppressed were more likely to have an active syphilis infection compared to those who had viral load suppression. And since this was a cross-sectional study, of course, you need to interpret it with a bit of care, because one, someone could acquire HIV because because they had a previous syphilis infection that broke the barrier that led them to increase their chance of getting HIV. But also, you could find that some studies have showed that when someone has HIV and they develop syphilis, they also tend to have a poorly controlled viral load. So usually they have viral load non-suppression. So it could go either way. But the overall fact that we showed that there was a high likelihood of having active syphilis and HIV co-infection if you had no viral load suppression. So this still highlights the fact that among people who are living with HIV, there is really great need to suppress their viral load and keep it undetected. And then the other factor that was significant was the number of sexual partners that someone had within the past 12 months prior to the survey, whereby those who had 4 or more sexual partners in the past 12 months before the survey had a higher likelihood of having active syphilis infection and HIV co-infection. So this still shows that from this, we see that, and also from literature, syphilis is also transferred sexually just like HIV. So the more sexual partners someone has, the more likely they would be, the more likelihood they would have exposure to an infection. So in conclusion, from this we see that although it's low, I still say that it's something that is quite high, given the magnitude of the infection, especially among those who are pregnant. And the prevalence of co-infection really varies between countries. We did explore why there are differences in the prevalence across countries, but still there is need to control the active syphilis infection within women living with HIV. And also we highlight that there is a higher prevalence of co-infection, especially among those who have no viral load suppression. And then this highlights the fact that we need to really strengthen our diagnosis for syphilis, especially among women living with HIV who are attending HIV clinics. And of particular interest, there's need to really target and look out for those populations that have been shown to be at high risk of developing active syphilis, especially, for example, women who have poorly controlled viral load suppression, the pregnant women. A lot is being done among pregnant women because, for example, in Uganda, most of the women who are attending their antenatal clinics are tested for HIV and also screened for syphilis. So these kinds of interventions are very key, especially in identifying syphilis infection among women living with HIV as they attend the antenatal clinics. And then also, as we are looking out to extend the services to this population, it's good to look at also people who have multiple sexual partners. In terms of strengthening diagnosis, it has several components. One, it starts with taking a detailed clinical history, especially as the women come to the clinics, and also ensuring that women access diagnostic services, and those who are found to have co-infection should actually be treated on time or initiated on treatment in a timely manner. So I would like to acknowledge one, the population-based HIV impact assessment program for granting us access to the data sets, and also my mentors from Makerere University who supported the work I was doing during the time when I was at Makerere University, and also the Uganda Cancer Institute. Yeah, thank you.